Okay, so to start with, I have no relevant financial disclosures or conflicts of interest. I'm mentioning lots of medications. I don't receive any funding from any pharmaceutical companies. So this is a practical talk on medications you may hear about. So I have 3 objectives today. The most important is I want to discuss systemic sclerosis as a gastrointestinal tract disease. So we have lots of sessions on skin and lungs, and I really want to just focus on how we think about systemic sclerosis primarily affecting the GI tract. I then want to discuss how do we screen for GI tract involvement and how do we manage common gastrointestinal tract complaints. And then if you'll indulge me at the last part of the talk, I wanted to discuss some of the research we're doing to try to understand how a multidisciplinary collaborative team is really important for both diagnosis and treatment of systemic sclerosis. So let's start with a question, and many people may be here for their first time, and to first-time session attenders, welcome. One of the confusing concepts, I think, when you first start your journey with scleroderma is when we use the term scleroderma and systemic sclerosis interchangeably. And so when we ask the very simple question, which systemic sclerosis patients are at risk for GI tract disease, we immediately go back to that mind frame where we say, well, scleroderma means hard skin. How does hard skin affect the gut, and how is that linked? And I'm really going to focus on what we call systemic scleroderma or systemic sclerosis, which includes patients that have an ANA blood test most commonly and scleroderma-specific autoantibodies, as well as Raynaud's phenomenon. And I point this out because if you have localized scleroderma, you may be on therapies that very much affect your GI tract, and you may have gut symptoms. But I really want to talk through conceptually is how we think about how Raynaud's in your fingers and Raynaud's of the gut are linked. And so when we're talking to answer the question, all patients. So whether you have distal minimal skin involvement, intermediate limited involvement, or diffuse skin involvement, we're defining the disease by skin, but we're recognizing that all systemic sclerosis patients have GI tract involvement due to that concept of Raynaud's of the gut. So let's talk a little bit more about why that's so challenging from that very first step of your diagnostic journey. So scleroderma specialists and rheumatologists oftentimes use this classification criteria to say, do I classify this patient as having systemic sclerosis? And there may be many of you in the room that have thought to themselves, I don't even know if I have this. You meet someone in a support group, the disease looks very, very different in different patients. But most of the time, the focus there is on the skin. So when you go into your rheumatologist or your care provider, they're pinching the skin in all these different areas and coming up with that modified Rodin skin score. And every person in the room would tell me that skin score has never helped their gut symptoms. So if we're doing that every single time and we're trying to decide where someone is in their journey with their GI tract, that assessment tool is not really helping us very much. But there's some other things that we do. We look for the Raynaud's phenomenon. We look for telangiectasias. We look for digital ulcers and pits. And that actually may have be one of the deciding factors on how we treat your gastrointestinal tract. And that's because commonly we think through systemic sclerosis as being the skin progressing and then maybe resolving over this course of time. But that concept of change over time in the gut is very much applicable. And if you look at that on that blue curve, that's our diffuse patients whose skin takes off really quick. We see listed up there in that corner, there's a GI tract involvement. Then we look at the red curve, and those are limited systemic sclerosis patients change over time, slower with regards to skin, but in many years down the road, we see malabsorption. So if we're seeing GI tract involvement early in the disease and late in disease, how do we bridge that management plan? Because disease activity and disease damage have kind of different conceptual ways we're going to think through this. And as long as we kind of take that classification criteria, we think through it differently. Now, the first sentence you read in most scleroderma textbooks, it says scleroderma is a vasculopathy characterized by fibrosis and autoimmunity. So if we take those classification criteria and we say, what is vasculopathy? What does that mean? Vessel abnormality. So Raynaud's and telangiectasias and fingertip lesions and abnormal capillaries All of those part of that classification criteria also correlate with GI tract disease. And then we really focus on those criteria. Can we then rationally think through wait for it, there we go. Can we rationally think through how then we want to approach the GI tract? So if we look at your fingers when you come into clinic and we say there's active Raynaud's, and then there was puffy fingers, that changed from that blood vessel not being very happy, and then the immune system causing a dysregulation, that puffiness coming, and then later causing fibrosis or scarring. Can we put that same concept in how we think through gut symptoms? And that's in fact what we've really spent lots of time and energy trying to do, is just putting this very simple concept of the clinical assessment of scleroderma that's actively screening for vascular and fibrotic or scarring skin and internal organ manifestations. How do we do that in the concept of disease duration? And how do we apply that to each individual patient? So you as an individual, how do we think through your GI tract symptoms? Well, certainly this is an important problem. So the GI tract is the most commonly involved internal organ involved in scleroderma. Let me say that again. You would think, no, it's got to be pulmonary. We have all these ways we screen for pulmonary disease. We've got treatments for pulmonary disease. But really, if we think through all systemic sclerosis, the internal organ that's most commonly involved is the GI tract. It presents in 10% of our patients. We'll talk a little bit about that. It occurs in almost all patients. Textbooks say 95% of scleroderma patients will have some GI tract symptoms. In our cohort, it's 99%. So if you're asking the questions, at some point in time, you can have reflux, heartburn, bloating, distension, constipation, or diarrhea. Let's pay attention to that and know how to treat it. If we don't treat it, if we don't pay attention to it, mortality can occur. So there's some challenges, of course, and this is where I think there's been a real lag in research and a lag in our recommendations back to patients. So it's very different in each different patient, and there's different triggers in different patients, so it makes it hard to do large cohort studies. Unlike an autoantibody, so if you have an SEL70, we know as rheumatologists, we better pay attention to your lungs. If you have an RNA polymerase III antibody, we as rheumatologists say we better pay attention, not miss renal crisis. Turns out all antibodies or absence of antibodies, people can have GI tract involvement, and it can be quite severe. So we really need to understand how to interpret symptoms, even if there's absolutely nothing in the way of laboratory or diagnostic imaging findings, and many of you in the room might say that. It's very frustrating. You'd say, Tracy, I have horrible symptoms. My GI tract questionnaire is moderate severe. I go in the doctor, they do all these studies, and they tell me nothing's wrong. Counterside, we have the same thing. We have patients filling out the GI tract questionnaire, mild to no symptoms that visit. We get a CT for interstitial lung disease, and there's a patchless big esophagus. And the question becomes, how did the esophagus get that big but not have any symptoms? So it's really very difficult to study this methodically and well. And again, like I said, at the very end, I'll tell you how we're trying to change that. But I do want to point out one of the things to be aware of if you've had this nagging cough and your doctor keeps getting the pulmonary function tests and the CT and is reassuring you and saying, don't worry, your lung disease is stable. Just remember, cough can be a manifestation of esophageal disease. And so it's important to sort of think of systemic sclerosis again as a GI tract disease. Now, one of my favorite sort of screening articles in systemic sclerosis was an article written in 2017 by Christopher Denton. And I like this article or this sheet for you to bring to your rheumatologist if you live somewhere locally and you may say, my rheumatologist doesn't seem to know much about scleroderma, and I don't know if I'm getting the right monitoring studies. This is a good reference for you. I was told that the handouts, they were trying to locate them and they couldn't locate them. I did turn my slides in time, I promise you. You have access to all of this, and if you email scleroderma.org, they'll get them to you, and you're welcome to all of this. But if you want to take a screenshot of this, this is like the money shot on how we think through screening. And the thing I think is most interesting is the GI symptoms, we just do symptom-based investigation. Well, that's kind of counterintuitive what I just said. Well, what if you don't have symptoms? Do we just ignore the GI tract until you have problems? Well, let's think through some of the kind of management and things that you could do that perhaps would improve your gut symptoms, or if you don't have any symptoms, your gut health. So one of the reasons that algorithm was, or not algorithm, I should say the screening recommendation said we only do a symptom-based exam is our physical exam is pretty limited. So we really don't get a great assessment of the GI tract just by us examining you. The exception to that is oral exam, and I have a slide on that on the next section, which can help us with referrals and team management. But for the most part, the abdominal exam is pretty limited, and the only real take home is if you have any fecal soilage, a rectal exam by a gastroenterologist is recommended, and that's because interventions can be done to really improve your quality of life. But symptoms are only present if your doctor only knows about the symptoms if we ask. And oftentimes we don't do a really good job asking about the GI tract in the clinic, mainly because we're limited in the tools we have to help, or so we thought. But let's talk through some of the tools that I think will help you. Now, I keep mentioning the rheumatologist because when you're seeing your rheumatologist in that 15 minutes to 30-minute appointment slot, they've got a lot to talk to you about. And we want to make sure skin and muscles and joints and breathing is stable. And so sometimes the GI tract kind of gets left out of the discussion. But we did a really good history. Shown in the blue box are all the potential things that could happen anywhere in the GI tract with a diagnosis of systemic sclerosis. And it can be quite daunting to sort of get to, is this present? But the best place to usually start is just symptom assessment. And if your doctor's not asking, make sure you tell them. The categorical severity just means, hey, today my GI tract overall is about a 10 out of 10 horrible. Or I'm doing pretty good from a GI tract standpoint. I think I'm about a 1 or a 2. Just that comment alone can help move care forward. The questionnaire thing is a little bit funny in that the Scleroderma Clinical Trials Consortium has this great GI tract questionnaire. I've talked about it for years. It really, I absolutely loved it when I first started practice because there's nothing more rewarding than having a patient fill out a questionnaire and making them better. So this was the questionnaire that I was like, oh, probiotics work for some people. Oh, a focus on nutrition works for some people if you do it every time. The questionnaire got taken down off of its kind of free platform, but I have the link there, which is why the handout's helpful. We'll get that. You can fill this questionnaire out yourself, and we're working with the Clinical Trials Consortium to get it back on this free version. But it asks 34 questions. It asks your general GI health, esophagus symptoms, bloating, distension, soilage, emotional health, social health, diarrhea, and constipation. In 34 items, it gives you fill it out, it gives you whether you're mild, moderate, or severe, and severe is worth having a discussion to make sure we make that better. Now, I really think that highlights the importance of questionnaires because they should minimally, oh, I got too excited there. There we go. They should minimally burden you. So I try to not give, when I first started, I'd give you every questionnaire, like, unknown to man, to make sure I was doing a good job and you're feeling well. This questionnaire in isolation is one worth doing because it allows us to, again, symptom quantify and identify. And if that's the only way we can screen for the GI tract, it becomes pretty helpful. Now, your doctor may know all the components of this questionnaire and just ask it and fill it out for you. So like for me, I know it off the top of my head, so I go through the questionnaire or the pivotal symptoms questions there. But at no cost, it can guide your care decisions. And what's the care decision? So you're not doing well, they can either choose to empirically start a medication to try to make it better, or they can say, does a laboratory help me? Does direct tissue visualization, that's an endoscopy, can that help me? Should we order a motility study, or is imaging indicated? And again, lots of ways to go about this, but from a rheumatologist perspective, we've got to try to decide, and this is, again, just showing esophagus, which one of these different studies would be indicated. And what I try to always do is first say, what have we empirically treated? So have I tried to make it better with just trying something? But then, is this study invasive, expensive, and is it going to change my care recommendation? So that's kind of 3 pivotal things. And I have lots of patients, particularly patients with longstanding disease, who've said, I've already done manometry and it was abnormal. Do I have to do it again? The answer is no. So really trying to think thoughtfully about which procedure is indicated for you and when tests become mandatory. So weight loss that we can't explain, or if you're considering a procedure, particularly an esophageal procedure, it may become mandatory to do more invasive testing. So I promised you some oral health, and that was one of the asks for this session. I point out that the oral cavity is actually part of the GI tract, and it's for that reason that we should start by looking at the mouth. This got really tricky during COVID, trying to respect people on immunosuppression. Do I take their mask off? How do we do that interaction? If you've noticed changes, make sure you tell your physician, I'm comfortable taking off my mask if you're wearing one, and I want you to look at my mouth. And what we're looking for is a couple of things that give us lots of information. So we're looking how well the oral aperture opens, how well the bottom of the tongue moves, and whether there's any issues with dental hygiene. That's particularly problematic if you have a lot of dry mouth. And that dry mouth is called sicca overlap. And that's also confusing terminology, because people say, do I or do not have Sjogren's? If you don't have the blood test for Sjogren's, but you have scleroderma, it's more commonly called sicca. So all these terms that doctors use interchangeably become sort of confusing as to what's causing what problem. But dryness certainly impacts your nutrition and as well as your ability to eat. So it's really quite important for your doctor to look at, so we know we should get on your care team. Maybe a plastic surgeon or a dermatologist, speech therapist, a dentist or nutritionist. But most importantly, we're going to want to think through management. So from a management standpoint, first and foremost, review your medications. You would be surprised how many times we are giving you a really drying medication and it just didn't get listed in your med list. So usually the medical assistant will put in your meds. One of the first questions, when you get into the clinic, is make sure your med list has been updated. Your doctor may not even know what you're on, particularly if there's over-counters that cause really dry mouth. That is really easy to fix if we find it. The next is oral facial stretching. So this is a recommendation that Janet Poole, who's one of my most favorite occupational therapists in the scleroderma world, recommended in some work we did with her. So every time you're in the shower, stretch your mouth. Have it nice and warm, stretch your mouth. And she says, do this cheesiest grin you can imagine over and over again. That actually, mobility has shown millimeters of improvement. You may say, well, millimeters of improvement, millimeters, over time, that adds up. And it's something that's free and easy to do. I also point out biotin products. Oftentimes, folks will have like almost a neuropathy of their tongue or mouth. Foods irritate. It's hard to get nutrition up. Knowing what products don't irritate your mouth, particularly when you're dry, can be incredibly valuable. Optimize your dental hygiene. Worth asking your doctor for a letter. Sometimes it works to get coverage for dental assessment if you don't have dental insurance. It's hit or miss. Sometimes it works, sometimes it doesn't, but be aware that since the mouth is involved with scleroderma, sometimes you can get coverage. And then I've starred and highlighted these ones that don't have randomized clinical control data to recommend them, but there's stuff on the internet, and there's certainly lots of questions about whether Botox injections, hyaluronic acid fillers, or lip rejuvenation can be helpful. What I think there's kind of two key points to this is someone who wants to discuss these procedures with you, whether they be in plastics or dermatology, should know what scleroderma is and treat lots of scleroderma patients. You want someone who's familiar with autoimmune disease, doing any procedures that you may consider. And again, we don't have randomized control trial data. So always people ask, is it safe? And the quiet answer is, we don't know. So why do we care so much about the mouth? Well, the key with the mouth is that it's the first entrance into your GI tract, but it's also the first entrance into your lung. And so when we think through, when I was talking about sick or dry mouth, sinus issues can cause aspiration pneumonia as well. So we tend to think about aspiration pneumonia coming up from the esophagus, particularly when you're sleeping, it gets into the lung. When we think about postnasal drip, that can also contribute. So if you're a scleroderma patient and you've had recurrent fever, maybe you've had imaging and your doctor's like, oh, there's good news. We don't see that classic interstitial lung disease, but there's this organizing pneumonia. That word is a buzzword. Or if you've ever had problems with your swallow and you've seen a swallow therapist and they're said, oh, you're at risk for aspiration. Or incidentally, if you've had a lung biopsy and they saw concerns for aspiration pneumonia, This is a very important diagnosis to make because you really want to protect your lung health, and it does impact how we treat reflux. So let's talk a little bit about reflux. Reflux is important because it occurs. It's the most common GI manifestation of scleroderma. Over 90% of patients will have some esophageal involvement with a diagnosis of systemic sclerosis. Real briefly, we talked about the oropharynx, where the pharynx meets the esophagus. The upper part of the esophagus is a different type of muscle called striated muscle. If you have an overlap with myositis or an inflammatory muscle condition, that upper part of the esophagus can be involved. Most commonly, when we're talking about scleroderma esophageal issues, we're talking about the lower esophageal area here. This is where that patulous esophagus occurs. This is a neurologic sphincter. And so again, if we always think about Raynaud's of the gut, Raynaud's over time to the base of the esophagus probably affects the nervous function of that lower part of the esophagus. When we're asking these questions about heartburn and difficulty swallowing, there's some kind of key components to it. The first, are you adhering to behavioral interventions? If you don't have your head of the bed elevated, so if you don't have the fancy bed, if you've tried a wedge pillow, you're trying to get gravity to work in your favor to protect the esophagus, that's something easy all patients could do. Are you on treatment? So if the patient's having reflux but not taking treatment, the first step would to be starting a reflux medication. We'll talk through those in the next slides. And then are you considering a surgical intervention, particularly for a reflux disease? That has a whole host of particular studies we need to do. If you're having difficulty swallowing, is it the initiation of the swallow? Is it due to dryness? Is it liquids, solids? Is food going back all the way, the regurgitant fluid from the stomach up to the back of the throat? Those two simple concepts of heartburn and difficulty swallowing, as I just talked through, can have lots of different ways we go about diagnosing and treating them, and that's why the questions become so important. Importantly, though, again, I'm going to keep coming back to this concept. Even in a healthy population, you don't have scleroderma, you can find reflux or GERD, and you can find regurgitation without symptoms. So again, it gets that real important concept. Are we doing everything in our power to prevent rather than just waiting till someone's having symptoms and it's bothering them? So I wanted to take some time to say, well, what are some considerations? What should we be doing for GERD? Again, smaller meals are important. Remember, the more you stretch the stomach, the more that food has to try to propel itself downwards. So trying to limit your serving size can be one way to battle reflux disease. Try not to eat more than 4 hours before bedtime. The head of the bed elevation we've talked about. And then if you've noticed there's irritants to your esophagus, certain dietary things that your gut just doesn't tolerate it, avoid those. Tight-fitting clothes, particularly when you're sitting down for a meal, can limit or can cause some heartburn symptoms. Avoid alcohol and tobacco. Again, that medication review becomes really important. The biggest bad actor here is calcium channel blockers. We use a lot for Raynaud's. Sometimes when they're started these really, really high doses, and you don't need that really high dose. And you get by with a lower dose that doesn't cause such bad reflux. So again, know what medications you're taking and if they're at the appropriate dose. And again, dietary review can be important with a nutritionist. So treatment options we're going to talk through. So if you have reflux, we've got different categories of drugs. We can do coating medications, we can suppress acid, we can neutralize acid, we can give pro-motility agents. Another question I get asked quite frequently is, what about procedures? My reflux is horrible. What options do we have? I show this just to kind of point out what these terms mean. A Nissen procedures, where they take the top of the stomach to kind of cause a functional sphincter. This can only be done if there's no dysmotility. And conceptually here, even if you, in a snapshot in time, have scleroderma and you have no dysmotility, the question would be, will you eventually get it? So is this ever a good idea in scleroderma? Probably not. Usually the toupee, which is this partial Nissen, is more commonly done. That allows so that there's not a functional stricture that occurs. And then lots of questions on this magnetic sphincter augmentation device that got lots of, was kind of splashy a couple years ago, like, oh, this seems like it would make more sense for scleroderma. Maybe you go in, you have the sphincter augmentation, they can go in and take it out. I kind of point out it is still an invasive surgery. The long-term results in this are not reported, and we really didn't have the randomized clinical control data. So really, if you're thinking about a reflux procedure, you'd really want to make sure, did we treat you with everything we had in our toolbox before we went there? So usually treatment, we start with a proton pump inhibitor. If you have nausea or heartburn or sort of a reflux regurgitant symptom, usually you'll start on a proton pump inhibitor. If that's not effective, that usually is increased to twice a day. Remember, you need to take it 30 minutes before you eat for it to be effective. I've been surprised how many people have said, oh, I failed proton pump inhibitors, and they were just taking it when they got reflux. So know how to take the medication and how to up-titrate it. It's not perfect for diagnosis, even just the general healthy population, but it's a good step before you get into the gastroenterologist. Long-term use, so certainly 10 years more of proton pump inhibitor use, you really do want to see a gastroenterologist, even if your reflux is well maintained on that proton pump inhibitor, because we haven't adequately studied long-term double dose in complex diseases with uninterrupted use. The one thing to be aware, I mentioned the 10-year cutoff. So if you've had reflux for 10 years on your proton pump inhibitor, that's a good, like, hey, I need to check in with a GI doctor. But also if you're on your proton pump inhibitor and you're having breakthrough symptoms. So if you kind of maximize the sort of empiric treatment, you're still having symptoms, it's important. About 15 years ago, we used to have a handout we gave, and when the second you got diagnosed with scleroderma, we started you on a PPI. Some people in the audience be shaking their head and say, oh, I remember we used to do that. And we don't do that anymore because again, it's a symptom-based investigation. But there is one exception to that. If you've been diagnosed with interstitial lung disease, you get started oftentimes same day on a proton pump inhibitor, because it's thought if you were to aspirate contents into your lungs, those acidic contents cause a lot more harm. So a proton pump inhibitor empirically, if you have lung disease, is oftentimes done. Well, what do I mean proton pump inhibitor? They're listed all here. We've talked about you need to take them 30 minutes before the meal. That's important. And then there's been some things in the media, the cautions that I've had lots of patients say, oh, I don't know if I want to be on this medication. And the reason is, again, we kind of talked about long-term high-dose use hasn't been adequately studied, but you do need acid to digest. And so there's some concerns that micronutrients are not going to get adequately absorbed if you're on this really high dose proton pump inhibitor. And because you're not absorbing micronutrients, are you higher risk for fractures? There were some reports of some kidney issues, again, because you're not absorbing all the nutrients that you need to. And then long-term use had been linked to small bacterial overgrowth and a C. diff infection. So lots of patients said, I don't want these medications. I'm going to try something alternative. But they did do sub-analyses to say if you have symptomatic reflux disease, peptic ulcer disease, if you have H. pylori, if you have this Barrett's esophagus, which is the precancerous esophageal changes, eosinophilic esophagitis is where they go in, they take a biopsy, and you have these allergic cells on the biopsy. And then if you have reflux so bad it's reaching the back of your vocal cords and you're hoarse, or you're having a chronic cough, in these cases, that high-dose proton pump inhibitor, the benefits outweigh the risk. And so it's always this balance. We want the lowest dose that's tolerated for symptomatic relief. We don't want to overdo it, but we don't want to be so scared of these medications that we actually cause problems. So if you've had a proton pump inhibitor and it's not working so well, what other options can you use? There is H2 blockers. This is Pepcid, and many people will add this to their nighttime regimen. This acts on the backside of the cell. So that parietal cell that's making all the acid, that proton pump inhibitor acts on the front side, the H2 blocker acts on the backside. So we're trying to get that cell to not make acid before you eat. Now over here, sort of the rescue medication. So let's say you decided to go out and you had a lovely meal with friends, and you should do this, but you got something that's, oh, I'm gonna pay for this. I'm feeling it already. And that happens. So you have some other drugs in your arsenal. These are those sort of coating or soothing medications. I point out though, antacids, Always, these are over the counter, so always turn the prescription over and look at the components of it. If there's a lot of calcium in it and you have really bad calcinosis, I've had many patients say that makes their calcinosis worse. Not enough to publish on it or to make it general knowledge out there. It's kind of that, hey, I think my calcinosis is worse. We didn't quantify it, but a tidbit there to be aware of, because there's lots of different antacid components or antacid selections out there. Magnesium, just remember that has laxative effects. So let's say you eat something spicy and you're really constipated. Magnesium antacid is your choice, and that's fine. On the flip side, aluminum causes constipation. So kind of know those sort of components of the antacids so that you can take them thoughtfully and know what your GI tract is doing. Now, most of the time they combine the magnesium with the aluminum so that you get this balance, but you can have this little tidbit and work around that. And then lastly, just review your medication. I know I sound like I keep repeating myself, but there's certain antibiotics, your bone density medications, iron supplements, potassium supplements, and certain pain relievers have different equivalent of dosing, so you can either get IV or topicals or things that kind of bypass the GI tract. So just review your medications to make sure that they're not contributing to your symptoms of reflux or nausea. So next step. So you've got the medications, you feel well versed, you're doing the right behaviors, you're taking the right medications, and you go in and you still have reflux. What does your doctor do next? So I wanted to talk through the different options, and we're going to mostly focus on the esophagus again because it's the most common and we only have an hour together. But conceptually, what I'm going to really try to have you understand is why would we order this, and is it worth your time in doing it? So a barium esophagram sometimes is used in conjunction with a speech therapist to assess if you're aspirating or food is going down the wrong pipe. So again, if you're having recurrent fevers, we're not quite sure about that. You say, yeah, sometimes I have this cough. I feel like food's going down the wrong pipe. This is a good indication for this study. It can be ordered in different forms as a cine, a double contrast study, but the real take-home message is this is, by contrast, trying to see how the barium moves through your esophagus. And it can identify strictures. If you said, oh, I really feel like something's getting stuck here, the gastroenterologist may want this prior to the endoscopy just to see if there is a stricture present and where they should focus their endoscopy procedure. Why this is practically very easy to do, and it's not very expensive. It doesn't give us a lot of good information outside of those contexts, though it may also be ordered in the context of an early diagnosis. You don't quite have enough classification criteria for scleroderma, but your rheumatologist is like, I think this is trying to become scleroderma or myositis overlap. This study may be ordered just to sort of understand where the esophagus is in the disease process. More commonly, though, you'll be referred, if you're having esophageal symptoms, right to an esophagogastrodiagnoscopy, or easily said EGD. EGD is an upper scope. It is usually the next line because it is diagnostic and therapeutic. So it's sure nice if you're going for a study that they can make a diagnosis and treat it at the same time. In particularly, when would you want to kind of talk to your doctor about this? If you're on high-dose immunosuppression and you're starting to have a lot more esophageal symptoms, you could have a fungal esophagitis. So thinking through to make sure there's not an infectious etiology for your esophageal symptoms. That med review, if there's some pills or medications you're on that may bother your esophagus, you can look and diagnose that. Barrett's and eosinophilic esophagitis, we've talked about. Those are biopsy diagnoses, so you would need to have the scope with a biopsy obtained. And then if you are having anemia and we're not quite sure the cause of it, GAVE can be diagnosed as that, and celiac disease requires an endoscopy with biopsy. If you have a stricture, the EGD, they can balloon dilate at the same time. If they find GAVE, they can use YAG or argon laser coagulation to treat it. So if they find it, they treat it, and you feel better. Practically, though, this is important to realize because I know a lot of you may come into a scleroderma center, so you kind of want to see all your providers and get all your procedures the same day. This is something that does require you to be fasting and prepare for and have a driver with recovery. Folks may ask, well, can I just have a capsule endoscopy? That seems a lot less invasive. Just the caveat on that, that's usually reserved for if they've done the scope, they can't find a cause of the bleeding, but they still have this anemia and they're worried about bleeding from the GI tract. They can order this to look for occult bleeding, particularly in the small bowel. but it is contraindicated if you have a stricture or gastroparesis, which we'll talk about in a second here. So a lot of times in kind of longstanding scleroderma, this is not an option for identifying those bleeding sources. And that's because you don't want the pill to get hung up and have a surgery to get it back. I keep doing that. Perfect. There we go. Okay, so really some additional testing. And again, I think it's super important. Do I need this testing, and what are we going to do with the information? So pH monitoring can help if you're having chest pain and we just can't find a cause. So it's taking the symptom and trying to say, is the symptom you're having correlated to reflux? It can also help us know we're giving you everything we have for reflux and you're still having those symptoms. We can say, is that therapy being effective? Again, kind of that concept of, are you a candidate for surgery? Because we've tried everything and you're still having refractory symptoms. It can be combined with impedance, and this assesses not just acid reflux, but non-acid reflux. So let's say your stomach doesn't empty very well, and so you have bilious or non-acid reflux coming back up. This can detect that type of reflux. And then catheter versus wireless space. The catheter goes through your nose. It's very miserable, I've been told by patients. And it's really important if you think you have reflux that's reaching up to the pharynx. If it were mostly worried about the lower esophagus, so let's say you have a patchless esophagus and you're not having much in the way of the symptoms, then wireless can be considered. So again, it gets back to what questions are we asking, and is it the right study for you in dealing with the symptoms that you're complaining of? Now, there's lots of additional studies that can be assigned with those pH impedance study, and that's really trying to get, well, what is the cause of reflux? So let's say your pH monitoring is normal, but you're still having esophageal symptoms. Then it may be a motility issue. I'm going to talk about esophageal manometry in the next slide, but I just want to point out here, it's an important problem for scleroderma patients, dysmotility. And so if we're thinking your stomach's not emptying, it's worth thinking through doing these additional studies. And you can see from a manometry standpoint, you can do it in different parts of the GI tract. You can do nuc-med gastric emptying studies. That's shown in the upper slide there, where you're eating radioactive scrambled eggs and they look how long it takes for that to empty from the stomach. And then radiopaque markers can be followed to see how long they empty. The Smart Pill wireless capsule was kind of very exciting in the scleroderma world because it allowed you to look at gastric emptying, small bowel motility, colon motility, and looking at the pH pressures of each of these. But again, contraindicated if there's strictures or significant gastroparesis. So its role in scleroderma diagnostically really still lives in the research space as opposed to providing that important information back. And I point that out because when you go to a scleroderma center, there's lots of things we could do, but it always should be the right thing for you to try to get you an answer for what your GI tract symptom is. So the one that's most commonly done is that manometry. And the manometry study looks to see how well the esophagus coordinates. And and there may be some people in the audience, this sometimes leads to a diagnosis of scleroderma. Just last week, I had someone referred from GI that said, I'm worried this patient has scleroderma. They had a scleroderma manometry. And that means that the lower esophageal sphincter didn't work well. And so because it has its own pattern, it's important to realize for all scleroderma patients, we really want to understand what causes that lower esophageal sphincter not to work so well. And that's my teaser for the research at the end of the slides. But let's talk through, again, the second part of the talk is all management strategies and what I'd like to think is useful information for you. So gastroparesis, it always starts by having tools in your toolbox. So know what you're eating and if you tolerate it. So two things I want to point out is high fiber foods were really good to say, you should increase the fiber in your diet. That'll help your bowel movements. If you've noticed that you've increased these healthy foods that have lots of fiber and you are miserably sick, there's probably a component of your stomach not emptying. So just knowing what foods have lots of fiber in it and minimizing those can be helpful. Additionally, if you've lost weight, you kind of think, well, I've got to bulk up. I'm going to just take a lot of fatty foods to try to increase my caloric intake. Similarly, if you eat these type of foods, butter, cheese, processed meats, and you just feel sick to your stomach, there could be a component of this gastroparesis. And again, you can get that gastric emptying study to diagnose it, or I always say more importantly, you can figure out how to manage it and minimize the foods. Another thing really important conceptually to understand is gastroparesis. We keep talking about nervous system function. So we have, these endoscopies and these procedures, but the nerves are not working really well. They're not sending the right signals. So if we're taking medications that make those nerves not work well, we're doing harm. So I really do try to minimize narcotics. I know there's a lot of patients that cannot get by without a low dose narcotic from a musculoskeletal symptom. So I'm not saying there's no role for narcotics in anyone, but early on, like, always ask your provider, do I really need this? Can we get by with an alternative pain management strategy? Tricyclic antidepressants, calcium channel blockers. Again, we talked about really high dose. I try to up titrate calcium channel blockers slowly and thoughtfully. Certain blood pressure medications, mood medications, nicotine and progesterone can cause gastroparesis to be worse. So just review your meds, make sure we're not making this worse. Treatment options exist out there. This is really tricky though, because they're speeding up the stomach emptying and movement of the upper intestines. They work, but they're associated with cardiac toxicity. So a lot of these have been pulled off the market, and gastroparesis medications are probably best managed not in the rheumatologist's office, but in the gastroenterologist's office for this reason. Another thing too is treatment of nausea can be an important component of gastroparesis management, and a lot of those nausea medications interact with Plaquenil, which can really be a very important medication for patients with that SICA complex. So there's some complexity to the medications for symptom management. That's why I really like to highlight, if we can get there with diet or removing things that are causing it to get worse, far better than another pill in your belly. Botox injections, great for Raynaud's for fingers, not good for the gut. Again, that gets back to that concept of telling the nerves not to work in the gut, bad thing in scleroderma. So we get that question quite a bit. Is Botox contraindicated in scleroderma? And the first question I message my nurse back, where do they want to receive it? Gut, no. Fingers, yes. So it's not just the drug, it's kind of where it's being put. So small intestinal bacterial overgrowth is one of the things that can go with gastroparesis. We have lots of bacteria that live in our gut. Bacteria is our friend. So when we're born, our gut is like a rainforest. And after lots of Raynaud's events of the gut, it becomes more like Antarctica. So the bad bugs that can survive that kind of hostile environment overgrow. And so we want to try to get you back to a healthy GI tract. Bacteria help us digest food products and help us keep our nutrition where it needs to be. If you're having pain, distension, diarrhea, and fecal soilage, those constellation of symptoms, it's good to ask your doctor, do you think I have small bacterial overgrowth? The first thing they may do is say, well, let's make sure we've gone through medications associated with this. That's most commonly those really high dose proton pump inhibitors. Do you need twice a day proton pump inhibitors, or can you get by on once a day? And what about hormone replacement? Therapeutics, so those pro-motility drugs we talked about on that last slide, those are best done through GI. Do you need cyclical antibiotics? Cyclical antibiotics is a discussion on its own. I'm happy to take some questions afterwards. The long and short of this is bad bacteria overgrowth. Antibiotics gets rid of the bad bacteria. You give a probiotic, try to get the good bugs back. Bad bacteria comes back. And so the cycle of which antibiotic works for you, how frequently we cycle, how do we use probiotics with that? No one really knows that answer, but I usually think it's an individualized approach. And if you understand the concept, then you can kind of get there with the right antibiotic for you and the right probiotic replacement. What nutrition is good for you? And again, we sort of talked about that dysbiosis, or the bacteria not being at the right place. How do you put good bacteria back into the gut is a very individualized discussion. You may not have access to SIBO or small bacterial overgrowth testing at your center. That is okay. So the way that you diagnose this is a hydrogen breath test. What you do is you take a test sugar that goes into the gut, the bad bacteria fermentate it, goes into the bloodstream, and you breathe it out. And so they quantify whether they think that you have small bacterial overgrowth by this breath test. The problem is its sensitivity is not great. And so if you're going to get this really expensive test and then they're going to treat you for small bacterial overgrowth anyways, you sort of say, well, maybe I should be treated for small bacterial first. And then if it's not right, then do the test. That is an option. There's some laboratories in the literature that kind of help sway the physician on whether to do this test. I list them because you should know what they are. I personally don't find them as helpful to check routinely. The fecal calprotectin is just a marker of inflammation. So it actually tells me, hey, this is pretty bad and we need to pay attention to this symptom of fecal soilage if I see that positive. So with diarrhea and fecal soilage, it could just be your medications. I know I'm harping on this, but keep going through your medication list. Make sure you're not taking something that's causing your stools to run loose. If you've had recent antibiotics, I see this quite commonly actually in folks that get treated for digital ulcers. So because digital ulcers have been associated with GI tract symptoms, this can get missed. So you have bad ulcers and we say, oh, well, you just have that gut-finger relation of scleroderma. If you've seen lots of antibiotics, remember to discuss seeing whether you should get C. diff testing. And I've seen that quite a bit of times, that particularly if that diarrhea or fecal soilage is getting worse. Remember, if you've traveled, discuss that with your provider. I think the GI tract can kind of get blown off in scleroderma because, oh, you have scleroderma, but you can get common infections that other folks get. So think through that. If you do have these symptoms, there's really some good reports in the literature with the effects of pelvic floor exercises and biofeedback, and this is something that's worth investigating. There are therapeutics that can be used, again, best in conjunction with your gastroenterologist. And certainly dietary considerations. I talked to a nutritionist. She said, before I see anyone, I kind of want my first 3 questions is, do they take lactose out of their diet? Because you can develop a lactose intolerance as you age. So something that's kind of easy to do while you're waiting to get into a professional. Sugar substitutes are notorious for doing this. So artificial sugars, take them out, see if that improves your diarrhea. And then even if you don't have celiac, are you gluten sensitive? So you can, if you're not gluten allergic, are you gluten sensitive? And does taking gluten out improve your symptoms? Worth thinking about, particularly if you're having fecal soilage and it makes it go away. I will say that it's important to always think through malnutrition because we see this in a quarter of scleroderma patients. And this is regardless of body mass index and regardless of weight loss. And so we can do a pretty bad job by this MUST tool that basically says, have you lost weight and do you feel malnourished, if we don't really think through what nutrition you're getting. So if you feel, I oftentimes I ask that question, do you feel like you're malnourished? If someone says yes, then that is, you should contact some additional laboratories. So that's really where like that pre-albumin, these labs can kind of help us. And then additional thinking through, well, why do you feel like you're malnourished? A lot of people are worried they have a lot of food allergies. A food allergy assessment is a reasonable thing to do. Or they say, I've just had to eliminate everything from my diet and I just feel like I'm not eating anything. In that case, a dietitian can be really helpful to fix that malnutrition. Because if you ask me, it's not so much that double day PPI that's causing these associations, more that we're not doing a good enough job detecting micronutrient deficiencies. So very lastly is this sort of concept of lower tract. Colonic involvement in about half of scleroderma patients. That's most commonly in the anal rectal area. Fecal incontinence is something people get really nervous to talk about to their rheumatologist. And I've had patients say that, like, well, I don't think this is really this doesn't have anything to do with my scleroderma. And I go, oh, no, this does. Fecal incontinence is something your doctor wants to know about, and that should refer you appropriately to the gastroenterologist. And again, like I said, that is an exam conversation as opposed to just referring you for a colonoscopy. And so fecal incontinence, make sure you're meeting with the gastroenterologist. And then certainly you should be aware that they changed the colon cancer screening to age 45, and that if there's anything that we think needs therapeutics, that would be something that's a best conversation rather than a screening colonoscopy. So there's nothing worse than you had your screening colonoscopy and the provider didn't even know you had scleroderma. So it's better to have those conversations for anal rectal disorders in the office with the person doing the procedure rather than just ordering the study. So the reason we're going to shift here in the last bit to what can we do a better job with? So there's lots of investigational procedures that GI doctor can order, and it can feel overwhelming. And we've touched on most of these conceptually of what they're trying to identify. But what we really became interested in is how can we better understand if blood is not getting to the gut? So a colonoscopy is going in that luminal surface. We're looking, and a biopsy is just going to take a little luminal soft tissue biopsy, or luminal mucosal biopsy, excuse me, of that area. How do I really understand what the blood vessels are telling that GI tract to do? So you can see there's blood vessels and nerves, and how over time in scleroderma do those change, and how can we investigate that in a thoughtful manner to help our patients? Shown alternatively, healthy gut has lots of fingers. The surface absorption is how you get the nutrients from your GI tract into your bloodstream. If you have Raynaud's of the gut and there's spasm and all that surface area is lost and those blood vessels are not working well, so immune cells are coming to the party and they're laying down scar tissue, that becomes a diseased gut. So how do we make sure that we keep a normal, healthy gut healthy even if someone has Raynaud's? So what we decided to do is that we could take that same concept of I can do capsularoscopy in early disease and follow the fingers over time. Well, I was also doing that in the mouth. So if we can look at the fingers over time, we can look at mouth changes over time where we see blood vessel changes followed by fibrosis. So how do we think through that? So we became interested in this sublingual camera device, which is capsularoscopy of the GI tract. And what that does is it looks at the blood vessels in the, underneath the tongue, and it quantifies the size of them and how the blood cells are getting there. So is there the density where we want it to be? And then it gives this kind of interesting measurement of health. So this glycocalyx. So the luminal side of the blood vessel, so your blood vessel is nice and healthy. This glycocalyx tells your gut to whether it's going to transmit signals of inflammation or whether it's not happy. Sorry. We started a little bit late, so I promise I will end on time, but stay for questions. So the reason this is important conceptually is we do know that when the tongue gets thick like this, GI tract symptoms get worse. That's what that diagram figure is showing you, is a tongue that has a lot of fibrosis. Symptoms in the lower tract are quite prominent. And then when we look at scleroderma and healthy controls, we see the density of blood vessels under the tongue drop out. And so that kind of talks conceptually to if you have Raynaud's of the gut, we can now quantify it. And we can quantify it by how bad your symptoms are. So it turns out patients that have really good, robust, healthy blood flow underneath the tongue don't have as much in the way of symptoms of their GI tract. And so these GI tract questionnaire scores is that 34-item questionnaire I mentioned in the very beginning. And so here is just showing you that if the blood flow underneath the tongues is not good, GI symptoms are worse. And it turns out that it's particularly helpful when people have bad reflux and bad constipation. That's when the scores were the very worst. And so we said, okay, well, those are important symptoms that we want to pay attention to, rather than blowing off and saying, take reflux medications and take some Miralax. We actually want to understand what those symptoms mean. And really the important thing is we did show over time that the longer you have the disease, the more important these markers become. So the vascular function really changes as the disease progresses. And we thought this was particularly important because when we looked in the literature of these full thickness biopsies, so when you go in and you do a biopsy, there's doing these mucosal biopsies. For research purposes, they do full thickness biopsies. They do the whole tissue that allows us to look at the nerves and the muscles and all of the different tissue information. And sure enough, it was really interesting. All these nerves that were separated from the blood vessels, and that nervous system cell was chock full of nitric oxide receptors. So the same way that we're trying to treat Raynaud's of your fingers, that seems like the blood flow of your gut's really quite important. But we would never go taking full thickness biopsies of your stomach to try to prove this over time. So we did a small project looking at this thing called computational molecular phenotyping, and we took different scleroderma patients that had limited disease duration and long disease duration, and we tried to say between healthy controls and scleroderma patients, what's a commonality here? And what we really thought was interesting is in the early diffuse patients, so someone with lots of disease activity on the skin and fingers, so we could see that in clinic, That biopsy of the GI tract similarly had lots going on. So all the molecular phenotypes were sending out signals of distress. When we looked at all comers, so all 3 of the scleroderma specimens, and again, this is a small study, but conceptually, just making the point I'm trying to stress, is this arginine, or rate-limiting substrate for nitric oxide, this blood flow rate-limiting step, was abnormal in all 3 scleroderma specimens. So we said, okay, this is really very important for us to understand. If ischemia reperfusion is causing ulcers and causing skin changes and causing, over time, perhaps components of the pulmonary hypertension, what is that ischemia reperfusion on a micro level doing to the gut, and how can we study that better? So we decided to take cells from the bloodstream, and we made those into something called an inducible pluripotential stem cell. It's a stem cell. So it's you, but it's a stem cell. We looked at your stem cells with scleroderma versus healthy controls. And we said, well, is there any differences? And it turns out these nitric oxide genes were different in the scleroderma patients versus the healthy controls. I'm going to highlight these are very, very small sample sizes. So this is not like, oh my gosh, she solved scleroderma. This is more so, I'm talking again, perfusion of the gut. How can you take this information back and think through? And so because these differences exist between healthy controls and scleroderma, the $1 million question becomes, well, how can we fix it? They're abnormal. If I was born with this or something triggered this, it's not very helpful. Is there something we can do? So we took these cells and we grow these cells and we test them to see what makes them act funny and do different things. And the good news is, at baseline, even though they were different, they acted just the same as healthy controls. So they had some differences, but they're behaving themselves and acting normal. However, at baseline, if they're acting normal and they're doing the right thing, what we really want to know is what makes them act funny. So then we injure them. So if you add inflammation or you scrape those cells off, 2 things happen. They move really funny and they try to repair themselves really robustly. And then the other thing that occurred is that they leaked or they didn't work well. So what we took this to mean is that our scleroderma blood vessel cells that were trying to recapitulate what's going on in the GI tract really don't like to be injured. So they have this really hyper response to injury. So is that a dietary injury? Is that how do we take that information back to the clinic? And I point out, as rheumatologists, we're really good at skin and muscle and laboratory assessments. That's what we're trained in, and we do a lot of that. And a shout out to Rachel Lando, who does this patient care movement. She's really taught me the importance of exercise and trying to get good blood flow to the joints and muscles, and all that's super, super important. But then it also made us think, can we do a better job with this concept of making our blood vessels function better and behave themselves? So if you have interstitial lung disease, should you be in pulmonary rehab to be really working on an exercise program? If you have endoscopy or impedance or manometry issues, are you meeting with a nutritionist to talk about what diet is best for you? And if you have wounds, how are you integrating movement into your daily regimen? So if scleroderma GI tract disease is all because the blood vessels were not working well in your gut, exercise is free to us, and anything that vasodilates is helpful. That will just conclude by saying that I have the great honor and privilege of working with many different scleroderma centers around the United States that really are trying to understand the GI tract. And we have 2 recent studies looking at how can we get good recommendations to patients. The one most important thing is tobacco use or smoking was far and away the worst thing for the GI tract. And we don't do probably a good enough job stressing that. We say it for lung disease, but for GI tract, if you're a smoker, please stop smoking. So in summary, and I think I finished right on time with our technical delays here, but really, make sure you're telling your doctor about the symptoms you're having. That online questionnaire is helpful, but that questionnaire allows severity grading and proper test ordering. So even if you can't find the questionnaire, you can't remember what the questionnaire is called, know that you can say, I have my GI tract symptoms on a scale of 0 being no symptoms and 10 being awful, are what number are you going to put to it? That's a helpful discussion. Are you having fecal soilage? Important discussion for GI referral. And are you on these empiric symptom relief medications? Because that helps us know when you have to go for a procedure. Oral assessment. So I added that for the request, and I thought it was really important. If you're not having your mouth looked at, make sure that you talk to your rheumatologist about having a dentist do it more properly. And then I always like to conclude by saying the true, like really doing a good job at this, getting you good information back, requires us to work together as a community. So I always want to thank you for participating in research studies. It really helps us understand how to make progress forward. And I always pause and thank my great collaborators that have helped me. Most recently, Dr. Rishi Nayak, who's joined the Scleroderma Foundation on the Medical Advisory Board, is an esophageal expert. He really wants to help us do a better job with this. And with that, I would like to acknowledge all the people that have helped me over the years and open it up for discussion and questions. And like I said, as long as the room is allowing me to stay, I'll stay as long as you want. You can email me too. I'm happy to help. And I thank you for your attention. And I will put on my glasses and look at online studies here too. Perfect. And I'll just repeat the question if that's okay, because it looks like we don't. And we're just going to go in like a circle. So please, ma'am. Uh-huh. So I'm going to repeat it. So with esophageal symptoms and gastroparesis, there can be this symptomatic popping or that you're feeling. Have you had this that swallow evaluation with speech therapy? But so this is the key. Ask when you, that speech therapist, when you're experiencing that pop, say that's what I'm interested. So oftentimes there can be this kind of mechanical change, and the key there is if the mechanical change is not a stricture, so you don't need a dilation, and is not putting you at risk for aspiration, the pop in and of itself is you don't necessarily need to worry about. Though it's alarming of a symptom, you can feel it, but you really want to do that evaluation and say that's it, that's the symptom. I've had patients who said the exact same thing, and they say, oh, the speech therapist saw it. But then I read the report, as long as it doesn't put you at risk for aspiration, and as long as you're able to, there's no stricture to dilate, then I say, okay, at least we know what it is. I think the key is oftentimes if you've had long-standing esophageal symptoms, there is that motility component. And your point is really well taken. There's not if you're on pro-motility medicines and you're on proton pump inhibitors, you're doing all the medical management. Is there anything we have to make that pop go away? And I would say leave it well enough alone if your airway is protected, as well as no stricture formation. Great, endoscopy. So the question was, how often should you have endoscopy? And so the key there is any dysphagia or any difficulty swallowing. If food's getting stuck, that you need to go in now and dilate. Now, that's where the individual approach comes into play a bit. So it depends what balloon size they're using and whether they think that the tissue is quite friable. So there would be some GI doctors who say, I just go in once a year and kind of prophylactically stretch. The tissue seem healthy. There's other patients that say, well, my GI doctor said I can't do that. And that's because when they dilated, it looked like there was that kind of fibrosis or change over time made the tissues at risk that they could cause perforation or problem. Now, so that's why you get different answers there. Now, the key, though, is who is the answer coming from? And that's where I ended, and I said, I'm really very blessed to work with an esophageal expert. So you want someone who, gastroenterologists are fantastic. They do lots of endoscopy, but your endoscopist should know what scleroderma is and feel comfortable talking to your rheumatologist so that you can come with a really personalized approach. But great question. So you're probably in a good place if they are able to. Sorry. The answer was there. She's in a gastroenterology clinic, and so if the rheumatologist and gastroenterologist are working together, you're probably in good shape there. And I'm just going to go in circles and come back. So yes, hi. So fantastic question. So I'm going to spend just a second to say what Conquer is. So, and then talk a little bit about my personal research, because they're a little bit different. So the Conquer registry is systemic sclerosis patients of 5 years duration and less from their first non-Raynaud's symptom. Well, that's confusing, right? So you have Raynaud's as your first symptom, your first scleroderma symptom. If you're within 5 years, one of those centers will come in or have you come to the center every 6 months. If you can check in twice a year and are willing to travel in the centers, we're all happy to see you. And it's really good because you get your questionnaires is a patient-reported outcome registry. So we take how are you feeling today, and then all the centers are kind of agreed to treat patients the same way and for free because we're not paid and you're not paid. We work together as a community and we say what is working and what is helping our patients do better. That for patients who may qualify is great. Now, there's going to be a lot of people say, well, there's another research project here that I'm not eligible for. That's so my local research project where we're looking at the GI tract and inducible pluripotential stem cells is all comers. So it's anybody with systemic sclerosis. And it is, as you can imagine with a lot of those assays, it's really, really expensive. So I can't branch it off to other centers. With the exception of the VA. So if anybody is a veteran, I do try to do telehealth from Visit 9. That's what I'm actually very passionate about is the care for our veteran population and figuring out GI tract symptoms. But that local project with the inducible pluripotential stem cells is only at Vanderbilt and the VA system. But the Conquer registry, look at those centers, and if you don't qualify, those are all centers that really are on top of this. The point I was trying to make there, that's where we found out smoking's really bad, like really bad. Okay, I'm getting the 5 minute. So I will. Yeah. Patulous, yeah, so what does that mean? So patulous esophagus is where the esophagus grows in diameter and becomes sort of floppy. And so when you get a high-res CT of the chest for looking for interstitial lung disease, sometimes you'll see that on the read, patulous esophagus. It means the esophagus is wide in diameter and put you at risk, of course, for reflux or aspiration. So it's a term that's used to mean like a wide diameter esophagus on imaging. Good question, please. Calcium channel blockers, was that? So the question was, does calcium channel blockers affect the muscles? No, however, so it's not a muscle effect, but it increases the blood flow to the esophagus, or in the same, so it increases blood flow everywhere. And that increased blood flow can make that neurologic sphincter not work so well. So the reflux can be seen on high dose calcium channel blockers. So one of the things that can be done is to try a lower dose calcium channel blocker. If it still treats the fingers, or if you're using it for blood pressure is still at goal, but you have less esophageal symptoms, that's better. I give the example of sometimes people are put on nifedipine 30 milligrams for their fingers, and maybe amlodipine 2.5 would be just fine. So it's just kind of knowing what the medication is, what its indication, and are you on a dose that could be lowered to improve your esophageal symptoms. Please. Yeah. 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 Mm-hmm. So I think that really actually highlights the value of gastroenterologists. So in the same way I know all the off-label stuff for skin and joints, GI tract doctors will know things that affect the metabolism of the gut and can help with symptoms. And so, absolutely, I thought you're going to, yeah. Well, and the most important thing that was caught. So unfortunately, what we've seen is C. diff gets missed because people say, "Oh, it's just your scleroderma. It's your scleroderma." So the key is if you have refractory diarrhea, to have the conversation with C. diff testing, and then for treatment, getting it officially done with by gastroenterology. Absolutely agree with you. Good point. Please, Farah. So good question. So microscopic colitis is where you're not getting adequate blood flow to the tissue and get some fibrosis. So you won't find it in the literature as like this correlation, but conceptually, I liked your question because if you're not getting good blood flow, then that certainly would contribute to a microscopic change in the bowel. So while you can't find that association very well reported, it is one of the reasons we're kind of passionate about doing longitudinal studies of how well blood flow is getting to the gut. Microscopic colitis is a little bit like reflux. It's so common in the general population. These association studies get a little bit hard. So they'll say, oh, well, no, you just have microscopic colitis with age and you have scleroderma. And I disagree in the same way that I think GERD and any GI tract manifestation in scleroderma, really want to think is that vascular based. All right. And we need to let someone in. You give me it's 5 o'clock. Okay, so I am happy to stay over here and answer any additional questions. Anyone on the online chat, I will answer those here after we finish. So I think you'll have access to those answers. And thank you again.